Ronson. Okay, so we're recording now. So Courtney, go ahead.
Hi, good afternoon, everybody. It's Courtney from PATH with Anna here, and Anna's going to give the update since we last spoke in May.
Thank you. Hi, Anna.
Hi, everyone. Would it be the presentation?
Oh yeah, I'm sorry. I always forget. Let me pull that up.
Okay.
Yeah. All right, can everyone see it?
Yes.
All right, so yeah, we are PATH. We assist all of SPA 8 area. This is our team. We have Jillian, Jenny, and Stephanie. And we service single adults of age 25 and over. We do the incentive case management, screening, housing location services, ongoing supportive services, interim housing referrals, housing voucher assistance, and so on. Next slide. This is pretty much what our schedule looks like. These are the cities that our teams are at during this date. We do divide and conquer. We spread the team out as much as possible so that we can hit as many cities as we can. This schedule is also based on case management appointments and is adjusted based on client needs. Next slide. We continue to use the lahop.org website for outreach referrals from the community and other constituents. Next slide. These are our numbers as of May and June. In those 2 months, we received 21 requests, 134 since July of 2020. For these 2 past months, we've received 9 LA requests from Carson, 6 LA requests from Gardena, 1 from Lawndale, 1 from West Athens, and 5 from Torrance. Next slide. Some of the community engagements or connections that we've made are the joint outreaches, Redondo Beach meal programs that have continued. At least once a month, we do the Redondo Beach Homeless Corps. We collaborate with police departments in Gardena, Redondo, Segundo, and Hawthorne. And we work with local shelters around the area. And then recently, we started working with tiny homes. Next slide.
Oh, any color on the kind of some of the encampments? I guess the one in Lenox is kind of the one that's kind of more pressing, right?
Yeah. Lomita McCoy encampment is slowly, I want to say, clearing out. There's still some of the individuals remaining there, and it's usually the same ones. No new faces have been seen. The Gardena encampment next to the Rosecrans Park has received several cleanups, and citations will start soon if the individuals don't leave the area. The Lenox encampment is still growing. There will be a cleanup. There was one a few weeks ago, but there will be another one on the 13th and 14th. And the citation or the notices were posted again today, or this morning today. And then there will be a joint outreach that will start at Dominguez Channel, which I'll go into detail in the next slide.
The Gardena encampment is the one on the warehouse site, right?
Yes.
Okay, yeah, no, they cleaned that out last week. So they cleared that out with the LAPD.
Ronson, they cleared it out on the Prologics building, but I just got off the SPA 8 care coordination meeting, and there's more people who've come back on the railroad tracks.
Yeah.
Okay, all right.
Yeah, they get cleared out, and then a few days later they come back, unfortunately.
Okay, all right. Thanks for the update.
Yeah, so from the start, the Dominguez Channel was kind of like a big concern that once we became aware of it, PATH took the initiative of trying to initiate a joint outreach between LaSalle Harbor Interfaith, MHALA, and St. Margaret Center, which will begin July 11th, which is next Monday. And it's next to the 190th and the 110 freeway. So in that little channel, we're trying to go out and see what's going to really be beneficial for those individuals, trying to resource them out or trying to see what their needs are. Our goal also is, once we get a little more familiar with this area, bringing in the Venice Family Clinic, which has continued to join PATH in several outreach hotspots and providing medical services. They have continued to go with us to the Lenox encampment and providing their services there as well. So we're trying to, they have readjusted their schedule, so now they're going to be joining us on Mondays instead of Thursdays. And then in Torrance, the PATH team assisted with getting individuals to the tiny home village. We have referred some individuals on there, and we have some who will be intake sometime this week. We also were there on the 5th, which was yesterday, and we helped out with intakes, and we helped out with some home kits or welcome kits that they had for them, and just welcomed everyone that we could. On May 27 of this year, PATH housing team along with the outreach team hosted a housing resource fair for the participants. We got Tom from Shared Housing there and Ruby, and we also had Lisa individuals there as well. We were able to schedule 19 unit viewings for the following week for the participants that attended to that resource fair. It was a pretty good turnout. We were pretty excited and happy to see everyone there. Next slide. So these are our outcomes as of year to date. As a reminder, the cities did, I guess, reorganize a little bit, so our numbers do look a little different. But for SD4, we had 5 mental health individuals obtain services, 3 from SD2. For primary care, it's a little bit more convenient or easier to get them to accept the services. So we have 15 for SD4 and 22 for SD2. Substance dependency, we have 9 in SD4 and 13 in SD2. Increased income, we have 6 in SD4 and 3 from SD2. Permanent housing, we have 7 in SD4 and 11 from SD2. Our total caseload Our total caseload for SD4 at the moment is 13 out of, and we have 9 seniors. And SD2 is 26, and we have 10 seniors. Next slide. Our current efforts, we have continued with enrollments. As of year to date, we have had 29 new participants. From the month of May and June, we have had 3 from Redondo Beach, 1 from Lenox, 2 from Wilmington, and 3 from Hawthorne. We have continued with the rapid referrals, rapid rehousing referrals. Unfortunately, those that are on hold as of right now. We have continued our tiny home and pallet shelter referrals. We've had 8 so far, and we've had 7 to the Torrance tiny homes, which just opened. We've had 23 referrals for interim housing as well. For housing vouchers, we've had 75 interest forms submitted. 41 of those have been matched or have been invited to apply for the voucher. And 14 out of those individuals have received or have been issued a voucher already. Some of the extra strategies that we try to implement or try to get our participants into is direct placements. And this could be done through either their funds, problem solving, or COG funds, or PATH funds as well. We also try to use shared housing, SRO living facilities. For individuals who have health needs, we use recuperative care. And we also use interim housing with some case management available to them. Next slide.
Hey Anna, so with rapid rehousing it paused, and EHVs also paused.
Mm-hmm.
Are the income in your tool chest is now limited, right? Because now you're just talking about shallow subsidies, and even PATH lease up, they need some sort of income, right, to be housed.
Correct.
So you're I guess they're taking away a lot of your tools right now.
Unfortunately, yes. Thankfully, shared housing has a program that has some assistance for employment So they can get like a subsidy through them if they are in search of employment, if they're going to interviews and they're applying and they show proof of that. So they can get some subsidizing of their rental process or rental amount. So we try to use that route as well. If not, we try to work with them in finding employment and trying to link them to other resources that can help them out with that as well.
When do you think they'll restart rapid rehousing?
Unfortunately, I don't have an answer to that. At the moment,
So, with rapid rehousing right now is changed. So now people are
Yeah.
being matched. And it's time limited subsidy. And so the way for us now to ideally get people matched to a time limited subsidy would be submitting the interim housing referral. And so we're doing that with the hopes and prayers that at some point they'll get connected to a time limited subsidy program.
All
So
right, this is the whole revamp at LASA.
Yes,
Yeah.
yeah,
Okay, got it.
yeah.
Sorry.
Mhm.
yeah. And that's also one of our challenges that I have listed here, but I'll get to that in a moment. One of our challenges that we face also is staffing. Like I'm pretty sure most of us are familiar with that. We do have a new hire starting next week, so we're pretty excited about that. COVID restrictions, meaning that we can't really see participants or we have to be careful if they have some symptoms or something like that. Shelters are mostly at their max capacity or in COVID lockdown. So that also prevents us from being able to place individuals there or see some of our individuals that don't have a phone or a way to communicate other than in person. Also the lack of interim housing and the period for waiting after submitting an interim housing referral, that is also has been one of our challenges. Low affordable housing availability, especially for our seniors. Some of those need more, I guess, subsidized units based on their income or their set income. And so that has been a challenge as well. And lots of changes, that meaning the way that individuals get referral to rapid rehousing or now time limited subsidies, which will be the new name for them, that has definitely affected how our team will be referring individuals to there. And also streets of subsidies on hold since June 1st of this year. Hopefully it will come back sometime this summer. We're just waiting on it, but we're still searching for units. We're still trying to get individuals document ready and housing ready for when that time comes. Next slide. We do have some success stories. We have housed Mr. Patrick. He was a 67-year-old individual who had been facing housing uncertainty for about 10 years. The outreach team was able to refer him over to the recovery team as of last year. And with working with both teams, they were able to finally convince him to expand his housing options other than Torrance, the city of Torrance. He was very precise at first or at the beginning of wanting only to live in Torrance, which has a very limited amount of housing or affordable housing available to individuals. So we kept having a conversation with him, reiterating, validating his feelings or his connection to the city of Torrance. But as of June of 2022, he was able to find a 1-bedroom apartment in Long Beach, which he finally was able to call home. And for now, he's waiting on the voucher as well. Next slide. We were also able to house Mion in the month of May. She was staying at an LA shelter, but was originally from San Pedro, which is where the outreach team interacted with her. And Mion, after only working with the outreach team for a month, we were able to refer her to the rapid rehousing team. And within that same month, we found her placement at an SRO housing unit in Wilmington, which she was open to. She is awaiting for her voucher. She was a match or invited to apply for the voucher. So we're just waiting for the issuance and trying to get her income to increase, getting her document ready, housing ready, so that when the time comes, we can eventually house her in another more suitable unit for her. Next slide. Teamwork makes the dream work. These are just some pictures. On the left-hand side, we have our team at the Torrance Tiny Home ribbon cutting event. In the middle picture, we have our team members during our housing fair at the PATH office. We had some hygiene bags we handed out to the individuals who attended. And then on the right-hand side, we have the team at one of the joint outages at the Lennox encampment. Next slide. Some of the future considerations that we've had or we would like to ask is for city shelters, meaning that priority will be to those experiencing homelessness within that city. Also motel conversions. It could be for housing units, interim housing units, shelters as well. Consideration of empty lots of land to be reviewed or considered for housing options such as tiny homes or the pallet shelters, such as we're seeing in the city of Torrance recently. And also cities to continue to encourage property owners to work with housing vouchers as well. And senior focus, affordable housing. Next slide. You can find, or you can contact me and Courtney at this email addresses for whatever outreach needs you have or questions or concerns as well. Next slide. Thank you.
Thanks, Anna. Does anybody have any questions for Anna? I don't see any hands. Anna, thank you so much. We appreciate that.
Thank you.
Sherry Weaver, Spa 8 Director.
All right, good afternoon, everybody. Reporting live today from the Torrance Pallet Shelter, so we are
Nice.
getting our work done here. But just give you a couple of updates of our other existing interim housing sites. So San Pedro interim housing, we've got 3 vacancies current. Just got off quarantine, so we should be filling those pretty quickly. 27 permanent housing placements at that site. ABH, which is in San Pedro. Unfortunately, this site has been under quarantine for the past 3 weeks. This new variant that we have out right now is super, super contagious, and we're just really trying to get control over things there and working with the Department of Public Health to do testing. We have 25 permanent housing placements at that site. And then Redondo Beach Pallet Shelter seems like they are untouchable with COVID. They have no vacancies. They are not under quarantine, and they are up to 29 permanent housing placements. The CES individual system, I'm going to give you stats up through the end of May. We will have one more report out for June, which is the close of the fiscal year. We've had 245 new assessments completed. For rapid rehousing and recovery housing, we've had 45 individuals placed in permanent housing. Individuals that have been served through housing navigation that have been permanently housed has been 62 this year. Torrance housing navigation, we have another 13 placements, and then under Redondo Beach housing navigation, 6. Transitional age youth, our youth program, we've had a total of 57 assessments completed this year so far. We've had 13 people that have been permanently placed in housing, and then we've had another 7 that have increased their income. And then last but not least, the family system, we've had a total of 221 families assessed this year. 88 have been placed in permanent housing through rapid rehousing.
Nice.
And then another 20 that were able to retain their housing through prevention services. So they've had their rental arrears paid and was able to maintain their housing. And then 22 other ones have increased their income this year. So since I'm coming here live from Torrance Pallet Shelter, I guess I should talk a little bit about what we're doing. So last week we had 3 days worth of community engagement and really giving folks from the community an opportunity to come out and ask any questions, take a tour of the site, and get a little bit more hopefully comfortable with the idea of having this site located in their community. As was indicated, we had Wednesday, we had a ribbon cutting ceremony, which was really wonderful. I think we had close to 200 people in attendance that day. And then we officially opened on Tuesday, July the 5th. we began moving residents in. See, there's some pictures. Into the Torrance Pallet Shelter on the first day. Want to thank Path for coming out and supporting us. Really appreciate that effort. First days are usually pretty chaotic, but on day one, we were able to bring in 16 residents that day. We had targeted 5, but we've been known to be overachievers, so we brought in 16 that day. Today's work really focused on Columbia Park, which we've had a large number of homeless encampments over in that area. And these are really people that are a little bit more difficult to get into sites like this, and that are much more higher acuity. But today so far, and the day's not done, we've already moved in another 5 residents. So we are just over halfway full at this particular point in 2 days. And then just a quick overview for those of you that are not familiar with the site and the setup. So we have 40 available units. We have 3 showers and restrooms. We have an online on-site laundry facility, as well as a dog run. Staffing consists of 1 program manager, 2 case managers, 5 resident aides, 2 custodians. And at this particular site, we actually have 2 security guards per shift, 24 hours a day. Many of you may have heard that one of our first residents that came in was an 88-year-old woman. Her name is Mary. She was actually a resident of Torrance for over 60 years. I got to do her intake and learn a little bit more about her story. She was divorced in 1994. She had her own single-family home, which was actually paid for. And through the divorce, she lost her house. She worked in civil service as a federal aviation over at LAX. She's worked there for almost 10 years, and then was diagnosed with cancer. At that particular point, she fought cancer for 6 years. She said she left it in God's hands, and to this date, she is cancer-free. Consequently, she was not able to maintain her employment at LAX. So she went to go live with her sister in Miami, Florida. I think we can agree that it's much, much too hot, humid there, but she decided to come back to California. It was in April of 2021. She was able to get her own little room for rent. And within 4 months, the owner raised her rent to almost double of what she was initially paying. Her current income is SSDI. So obviously the affordability, factor was not within her income guidelines. So she started living on the streets. She said a lot of days that she was out there, it was really hard for her to believe that someone like her that has been successful would end up in a situation like this. But we're really glad to have her here, and she's settling in well. It's only day 2, but she's really glad to have, a place to call home for the time being. And then we will work with her on permanent housing. So I just really want to say that I've been excited. Yesterday was a flurry of activity. Today was some of the more difficult people, but things are really starting to fall into place. We do have a new partnership at this site. So Venice Family Clinic is going to be bringing out their mobile health van, and they will be doing everything from providing health assessments, enrollment and healthcare benefits if they do not have that already. They do behavioral health services, and once diagnosed, they also can provide medication if the patient prefers that. So their first visit here will be with us on Monday from 9 a.m. to 12. So we are really excited to have that new partnership as well. So that is it for my report. Any questions?
Great story, Sherry. Man, so amazing, that 88-year-old woman. That's just so great. And I just want to also add, the city of Burbank had like a dozen people there. And so we're already inspiring other cities to do the same. So it was great to see.
Sherry, this is Jackie. I just want to say, for you to have moved in so many people so fast is really fantastic. Thank you for the hard work.
Thank you, Jackie. Appreciate it.
And I think your ribbon cutting was a successful event that people really got into it, enjoyed it, and were surprised at what they saw. So it was a good job.
Yeah.
Any
Sure.
other questions, comments?
No, I just want to add that engaging the community the way you did for 3 full days is so important to get them on board and understanding before they can whine and complain. So that's another part of modeling what you've done. Excellent.
Thank you.
Okay, I don't see any more. So we're gonna move on. Ronson, go ahead with SPA 8 updates.
Yeah, I'm just gonna keep it really short because we're running a little bit behind. I want to make sure my buddy Victor from LASA gets his full time. He was one of my favorite directors at LASA, and so I'm so glad he's here with us now and under the Department of Health Services at the county. But I wanted to preview some interesting data that Lori got about the people that applied for California's rent relief. And the number of cities that were very much affected by this program in a good way. I see a lot of cities on our call today, which is great. We got Manhattan Beach, Torrance, Gardena. But as you can see, a lot of people were affected by not being able to pay their rents during the pandemic. And so these were the number of people that were facing evictions, number of people that applied, and number of people that paid. We'll dig into this a little bit more later on. But I definitely want to give Victor some of his time back for his presentation.
Okay, good. Thanks, Ronson. I appreciate that. So without further ado then, to give Victor his time and maybe a little more, we're gonna have a presentation, DHS Housing for Health Mobile Clinic. And Victor, you're on.
Thanks, Rodney, and thanks so much, Ronson. Great to see you. Thanks for having me and my colleagues on today's call. Really good to see a few familiar faces on the call. Should we share our screen or I know we sent the slide deck.
Yeah, if you have it up, go ahead. You can go ahead and share. Yeah, if not, I can pull it up too.
Well, I got it right here. All right. Can you see my screen?
Yes.
Beautiful. All right. Well, hello, South Bay COG. Thanks again for having us on to talk a little bit about our DHS mobile clinic program. We had originally reached out to South Bay COG back in June, and we were hoping to get you before the end of the month, but this is just when our scheduling and I believe yours lined up for us. And so there's going to be a few slides that are slightly outdated because our COVID response project, our COVID response teams sunsetted at the end of last month, so last week. But we did want to make sure that we got you information about what's coming up next. So I'm going to go over just really briefly what we were able to accomplish at DHS Housing for Health through our COVID response efforts, and how that has led to the launch of our newest program, the mobile clinics. So over the course of the past 2 years, starting way back in April of 2020, Housing for Health has been responsible for the county's COVID response efforts for people experiencing homelessness. So we deployed sheltered COVID response teams that provided surveillance testing in shelters, vaccination services directly in our housing sites. We supported contact tracing and outbreak mitigation and risk mitigation efforts. We also had unsheltered COVID response teams that did a lot of testing at encampments, surveillance testing to identify potential outbreaks or spread of COVID throughout the pandemic. Also, those unsheltered COVID response teams expanded out to do a lot of additional street medicine, harm reduction, and vaccination services that really, gave us the experience and information and knowledge that we needed to be able to move forward with the launch of our mobile clinic. We also had unsheltered vaccine teams that were doing pop-up clinics in riverbeds and alleys and on sidewalks and access centers and just anywhere that unsheltered folks might be able to obtain vaccine access. And just a whole host of additional support services, including this COVID support line where people experiencing homelessness or their outreach workers or caseworkers could call and schedule a team to go out and provide a COVID vaccination for someone. A pharmacy where we were able to dispense COVID therapeutics to people who were testing positive, who were in shelters or in encampments. a team of city county coordinators that helped make sure that we were doing all of this in close alignment with the strategies of our municipal partners and the resources that you could bring to bear as well. We had community health workers, we had teams of peer advocates that really successfully were able to go into the shelters they were staying at, or the encampments they were staying at, the surrounding encampments, and talk to their peers about the reasons why they got vaccinated and why folks might want to get vaccinated through one of our teams. We also did a whole host of other projects. We had harm reduction specialist teams. We had STI specialist teams that were deploying into sheltered and unsheltered locations alike to provide additional clinical services through the kind of COVID umbrella. As I mentioned, we did have a team of city county coordinators who would have been providing this presentation if their role hadn't ended very recently last week. But this slide just talks a little bit about what they did and how they connected to the community, to municipal partners, city county offices and other departments and stakeholders, other clinical partners and outreach partners, to make sure that we were leveraging all of our resources effectively over the course of these past 2 years to bring those life-saving and necessary resources into areas where our most vulnerable neighbors could easily access them. So as I mentioned, we did conclude, we had our last vaccine clinic a couple of weeks ago on June 27th, and have since closed out the rest of our COVID response efforts, while working to transition as many of the services and resources that we were providing to other community groups. We've been working very closely with our partners within the multidisciplinary teams to make sure that they've had access to point of care rapid COVID testing and other resources that they can continue to provide. We made sure that our interim housing providers continue to have good access to the Department of Public Health and risk mitigation and outbreak mitigation resources and strategies, and really just went through until the very last day to get as many vaccinations into the arms of people experiencing homelessness as possible. By all measures, it was a very, very successful program. We're very sad to have seen it ending. When measured against the most recent LA County full-time homeless count, which we know is relatively dated at this point, but it's the best number we have to kind of compare to. We were actually able to provide at least one dose of the COVID-19 vaccine to almost 93% of the population of people experiencing homelessness in LA County, and to fully vaccinate over 75% of the homeless population. Those metrics, those statistics actually exceed the vaccination rates that we have across the general population here in LA County. So we're really, really proud of our work. We really believe that through these concentrated and collaborative efforts, we were able to save lives and mitigate illness amongst the population of people experiencing homelessness. And again, as I've mentioned, coordination has been so key to this and to the work that we will continue to be engaging in at DHS through our mobile clinics. This slide here just has the bento box graphic that we use to describe the system of coordinated outreach that I imagine many of you are familiar with, where requests for outreach kind of get funneled through a central system and they're deployed out to the most relevant team or resource. And we really tried to make sure that all of our COVID efforts were, again, conducted within that kind of umbrella of the existing strategy and coordination. And we want to make sure that the launch of our upcoming mobile clinics also kind of fit within existing strategies, within existing coordination. I see Yvonne on the call. We're going to hop on a call with Venice Family Clinic and a lot of other street medicine providers tomorrow as part of a regular convening that we have to make sure that the delivery of street medicine resources are very coordinated, so that if we see any of those folks at the tiny home village that just opened in Torrance, we will know who to reach out to, because we know that there's a clinic that's there on site that's providing those resources, and that we're not kind of stumbling over each other. But yeah, why are we expanding with mobile clinics as we conclude the COVID response efforts. I just want to reference a couple of recent studies. I see Janie Roundtree is going to be presenting after we're done. I think that she was actually involved in this point in time homeless count mortality study published by Dr. Nicholas of DPH that really looked at the mortality trends amongst people experiencing homelessness in the year before and the year after COVID. That's the report in the middle here. And on the left, just looking at the mortality rates of people experiencing homelessness compared to the general population here in LA County, what the leading causes of mortality are. And then another study relatively recent that kind of combined studies across the country that looked at hospitalization expenses and readmissions for people experiencing homelessness compared to the general population, looking at trends, causes, outcomes. And what these studies show, and many other studies, is that hospitalizations and deaths are in higher proportions amongst people experiencing homelessness and increasing, unfortunately. You can see the chart on this slide here shows the number, kind of the raw number of people experiencing homelessness who pass away while homeless has increased year over year. You can also see that the mortality rates are increasing year over year. So as the homeless population increases, we would expect to see an increase in mortality, but we can see the mortality rate is increasing as well. So more people are dying homeless when you compare it to just the number of people falling into homelessness. And unfortunately, mortality rate ratios are accelerating much faster for Black people experiencing homelessness, other minorities experiencing homelessness. Hospitalization costs are much higher for this population. Readmissions are much higher for this population. Hospitalized people experiencing homelessness are often uninsured or underinsured, limiting access to quality primary or preventative care services, leading them to receive care when they are hospitalized. We're also seeing that overdoses are the #1 cause of death of people experiencing homelessness. And we know that substance abuse issues can create additional barriers to accessing primary care or healthcare in general. We also see that mental health issues are much more prevalent in hospitalized PEH compared to the general population. And again, that can present as a barrier to accessing care if someone has a severe mental illness or other mental health issue. When we were going out into encampments ourselves with boots on the ground over the past 2 years, we were completing encampment assessments every time we would go into an encampment, provide services, and we were really looking at what are the gaps in care that are available and accessible to the people in the encampments that we're seeing. And you can see that we completed thousands of encampment assessments representing thousands of individuals living within those encampments, and we saw an urgent, just a tremendous need for primary care. Very few individuals, fewer than 1 in 5 individuals indicated easy access to primary care services. Only about half indicated any access to urgent care services. Less than a third indicated access to needed women's health services. So you can see across the board, all of these kind of specialty needs, we saw large gaps that were not being filled when we were going into these encampments. Street medicine is something that's been available in LA County for a long time. We've got teams like Venice Family Clinic and their mobile clinic. They've been doing it for a while. We have other teams, UCLA, USC. We have Healthcare in Action that does some work in these areas. And so there's a lot of independent street medicine teams. We've also built a system funded through DHS that deploys outreach teams with a health component. You've got E6 representatives on the call today, so you're all very familiar with how Measure H funds these multidisciplinary teams to embed that health component within the team so that we can start to address some of those clinical needs that are on the street. Through the COVID pandemic, we really injected a lot of additional clinical services directly into those encampment areas. And that brings us to today, as the COVID response efforts have concluded, and we are getting ready to launch the next iteration of DHS's ability to provide direct medical and behavioral health services directly in encampments. And so to talk a little bit more about the mobile clinics themselves and the services that we offer, I'm going to pass it to my colleague, Taylor Smith, for the next slide.
Hi, everyone. The mobile clinic program has two overarching goals, and that first goal is to really provide consistent, low barrier, trauma-informed care that's comprehensive, patient-centered, and addresses the needs of the health, addresses the social and health needs of patients experiencing unsheltered homelessness in LA County. That second goal is to coordinate street medicine services among all providers in Los Angeles to ensure that we're linking folks to specialty and direct care services, medical homes, housing, and other supportive services. This slide is an overview of our mobile clinic structure. We'll have 4 mobile clinic units, and each mobile clinic unit will be servicing 2 service planning areas. On each mobile clinic unit, we'll have a medical team as well as a behavioral health team. And on our medical team, we'll have a physician, a nurse, and a medical assistant. Physicians, nurses, and medical assistants. We'll also have on our behavioral health team a senior clinical social worker, community health workers, an SUD counselor, and a medical caseworker. And then we'll have an eligibility worker who will help sign folks up for insurance and register folks, as well as a driver. We'll also have a psychiatrist and a clinical pharmacist that will be cycling through each mobile clinic unit. And above all of our operations, we'll have our senior physician and our director, Dr. Absalon Galat. So in response to that data that Victor shared earlier, we really want to make sure we have a comprehensive list of services. And so we'll be offering primary care services, being that that is a huge barrier for our population. So that includes vaccines, labs, medication. We'll also be providing urgent care services. So that's point of care ultrasounds, EKGs, wound care, and other urgent care procedures. As we mentioned before, we'll have a behavioral health team. So we'll be able to provide behavioral health services as well as psychiatry services. And we'll be providing field-based medication-assisted treatment, which is pretty neat. We'll be able to prescribe folks Suboxone, bridge prescriptions on the spot. We'll also be providing reproductive health services. If you look at this picture to the right, that's Dr. Galat in one of our exam rooms, and you can see the stirrups on the exam table. So we'll be able to provide pap smears on the mobile clinic units, as well as STD screenings and treatments. We'll be providing OB triage and prenatal care services, as well as transitions of care services from emergency departments or correctional facilities. And then we'll also be providing enhanced care management. How will the mobile clinics be deploying? We have this drop site and drop zone system that you can see on the screen. All of these dots are surrounding encampments, and they all connect to one point, which is what we call a drop site. All of those bubbles that are colored around these dots are what we call a drop site zone. So our mobile clinics will be following a bi-weekly route schedule where they'll be parking at a drop site, and they'll be supported by our satellite vans that will actually be able to go out into that surrounding drop site zone and service folks in their encampments. So we're really hoping to not only provide services on the mobile clinic, but bring services to folks and meet them where they're at, especially if folks have hesitations around leaving their encampments because of fear for leaving their belongings, or maybe there's other limitations that prevent them from coming to the mobile clinic. We'll be able to pack our providers up and go to them. And if there is need for transport to the mobile clinic unit itself, we'll be able to help transport that patient to and from. This final slide is just a point of contacts for the mobile clinic program. We have Dr. Absalon Galat, who's our medical director. We have Victor, who I think everyone on this call knows. And we have our staff analyst on the project, Cindy Ramirez, as well as myself.
That's it. That's our slide deck. We wanted to go quick since I know we're short on time, and leave a little bit of time for questions if anyone has any.
Yeah, so that was a great presentation. We really appreciate it, but I'm sure there's got to be questions. So anybody that's got questions, just throw them out there.
Thanks, Victor. I can get it started. Do you
Hi,
need
Russell.
reservations, or can you just drop in to these mobile clinics?
We're really hoping to really focus on serving a patient load of primary care patients that we'll be making ongoing reservations with. However, we'll always reserve 30% of our appointment slots for walk-up services. And so we're always going to have daily available appointment slots with the physician, with the SUD counselor, with the social worker, in case there are walk-up or emergent needs.
Yeah, I think it's great that you guys can handle so many different types of health issues at these clinics. I'm working on alternative crisis response model with the county Department of Mental Health. And I'm just wondering, would there ever be a scenario where we're triaging someone in alternative crisis response, and then we bring that person to you at one of your drop-in sites? Would that be a possibility in the future?
Yeah, that certainly could be a possibility if that kind of emergency response assesses that there's an urgent care need. The individual doesn't need to go into like the emergency department, and they'd like to be seen by a team that's kind of like specially trained for supporting this population. It's during like our standard business hours. We are deploying out of Rancho Los Amigos every morning in the city of Downey, and so we're gonna have to fight traffic to get to our drop sites in spas 6 and 8 each day. So our hours of operation will be roughly 9:30 till 2:30, 3 o'clock that we can see patients before we have to pack up and go again. So as long as it kind of fits within when we're there, we're absolutely able to take kind of those walk up, like, hey, this person needs someone to take a look at this wound, this rash, doesn't have any primary care, and that's the most important thing that they'd like to take care of today. Can we get them signed up for your clinic? Those are types of things that we can definitely take care of.
Okay, great. And then like, how do we, so what's the next step in terms of like getting us the drop-in locations, your schedule, and are there plans for like a SPA 8 contact person? It's just so our outreach workers know where to find you guys.
Yeah, absolutely. We've been doing a lot of presentations with our MDT directors, with our outreach learning collaborative, and other spaces where we can provide this information to our street-based engagement partners, our other street medicine teams. Outreach teams are going to have a direct referral system through Taylor to get their participants referred to the mobile clinic for our roving team in a satellite van to go and visit them and begin an intake with them. For other types of referrals, like from our city partners on the call here, we're really asking that we try to go with an outreach team first to assess whether or not there are medical needs that, for example, the medical component of the MDT isn't able to triage, then they would be able to refer directly to us. Janet, I saw your hand go down. I did want to clarify, we can help folks that are not impaneled to our mobile clinic. That's our kind of main goal, is to impanel folks and provide that primary care. But we can do urgent care services for anybody who needs them. No documentation status requirements, no insurance status requirements. We're the county, so we help everyone. But if we stumble across, for example, someone being helped by Venice Family Clinic, we want to make sure, we take care of the urgent care need in front of us, but then we get them reconnected back to their other street medicine team or their brick and mortar clinic where they normally receive services.
Awesome. Questions, more? Well, this is a great opportunity to find out how to get some mobile services.
Oh, and Ron, so to your question, our deployment site schedule is like 90% confirmed. We are making a couple of changes. For example, we have to make a quick switch up to our Lennox spot. We were going to park right there in the encampment, but it's gotten a little too big, and so now we're looking for a nearby parking lot that we could go to. But we can share that with you as soon as it's finalized. It should be done really soon, and then you can, we want it to be out there in the community so folks know where we're going to be parked when we're going to be there.
Okay, that's awesome. Okay, Victor and Taylor, thank you. Really a great presentation. So we hope that we'll start seeing you guys out here so that we can participate with your mobile service, get some help to some people. So
Beautiful. We should just be about a month or so from our full launch. And so we'll definitely circle back, let Ronson and the group know when we're out in the field delivering service.
we look forward to that. Thank you.
You guys
All
have
right.
a schedule being like published somewhere about like what cities you're going to be in when you're doing the mobile clinics?
Well, we're about like 90% finalized with that. As soon as we get that complete, we'll shoot it out and share it with this group.
I think Diana's from Gardena, so I think she's kind of reaching out to see where, if you want to use our city for a spot, she'll find a place for you.
And absolutely reach out to myself, to Taylor, anybody else on that last slide. The COG should have that slide deck. We're happy to discuss locations. If we can establish it as a drop site, it's at least important for us to know like where are the locations in your city that we should have on our radar, that our nurses, our community health workers should be aware of, folks who might need their services.
Thanks. Okay, seeing none, I think we're going to move on to our next presentation, which is from Janie Roundtree regarding homeless predictive tool. Janie?
Hi, it's so nice to see all of you and meet some of you for the first time today. I'm Janie Roundtree. I'm the Executive Director of the California Policy Lab at UCLA. And I'm going to briefly cover two different projects that we're working on right now with the county. One is focused on prevention and how to use data to find people who are at high risk of homelessness and what the county is doing to help those people. And then I'll touch briefly on our recent study with the Department of Mental Health, trying to estimate the prevalence of serious mental illness among people who are unsheltered. And just to highlight one finding, actually, I found it really striking that our methodology, which uses administrative data, actually was very similar to the gaps analysis that Victor just presented through a completely different methodology where they're actually assessing needs and encampments. So I'll try to connect the two presentations. So without further ado, let me start my presentation. Please feel free to interrupt and ask questions. I'm happy to do that. And Ronson, maybe you can tell me if we're getting questions. So just a quick note about who we are. We're a research lab with sites at UCLA and UC Berkeley. And we're a little bit different than your typical academic research partner in that all of our research is designed collaboratively, primarily with public agencies and focused on what we hope are really urgent, actionable questions. So we work a lot on homelessness with LA County, DHS, Department of Social Services, DHS, but also with the city and with LAHSA. We work in a bunch of different areas that I won't talk about today, but they include criminal justice, education, labor and employment, and expanding into health policy research. And we specialize in doing quantitative research. So really thinking about how to utilize really large data sets and link them together. And that's particularly important for homelessness because as people experience homelessness or at risk of homelessness, they tend to be interacting with a lot of different systems, whether it's the county jail, safety net programs like general relief, or if they're a family, maybe it's CalWORKs. They're coming in and out of mental health care potentially. So to really understand solutions to homelessness, you can't operate in a data silo where you're only looking at one of these things and not the whole picture. So that's a little bit about who we are, and happy to answer questions about our work. We've been doing a project now for about 4 years with the county focused on predicting who's at risk of homelessness among current county clients, and then helping design a solution to prevent those people from becoming homeless. It was covered in a recent LA Times article that you may have seen, and what I'm going to do today is just really hit the highlights because I don't want to bog down your meeting in tons of scientific detail that may or may not be interesting. But of course, if you're interested, I'd be happy to talk to you offline. So what is the policy problem here? I think we all know why preventing homelessness is so important, because the county is better at housing people than it's ever been with all of the new resources online. Yet year over year, the homeless population is growing, and it's because of inflow. It's because of new people experiencing homelessness that we don't catch, particularly the people we could catch who are attached to mainstream services, right? But targeting prevention is really, really hard. The vast majority of people who are coming out of the jail, who are enrolled in general relief, or who might be enrolled in public mental health services, they're never going to become homeless. And you want your prevention dollars to go to people who are going to become homeless if they don't get that intervention. So to put it in perspective, there's a lot of numbers on this slide, but basically there are about 2 million adults in LA County that are getting some kind of public service, and less than 1% of them will become newly homeless in any given year. So it's a real challenging problem if you're a public administrator, because if you served everyone who appeared to be vulnerable, you might end up spending a lot of money on prevention and not having any effect on inflow at all. So what do people do when they design prevention programs? There's really two approaches to what we call the targeting program. The first one is wait for people to self-identify. They're going to raise their hand and say, I'm at risk of becoming homeless. I'm about to lose my housing situation and I need help now. Self-identification alone is not an accurate way to figure out who's actually at risk of homelessness. Most of those people won't experience it. But combining self-identification with program eligibility criteria and screening tools can be effective. So let's say you have people self-identify and then you set an income eligibility requirement, like you have to be at 30% or lower of average median income. That can be an effective way of making sure your resources are going to the highest risk people. Another way is to ask questions that are similar to what you would see on a triage tool. So have you had a recent incident in your home? Have you had a history of behavioral health issues, that kind of thing. LAHSA does use eligibility criteria and a screening tool to guide people into prevention. And we have a report on our website that evaluates those screening tools and makes some suggestions for improving them. But we've been trying a totally different approach that's much more experimental, which is, can we use all of the county's information from jail stays, probation, substance use treatment, enrollments, safety net enrollments? Can we use all of that data, link it together and analyze it to see if we can predict who is at highest risk of becoming homeless? And this is a data science technique, sometimes called predictive modeling or machine learning, where the end result is literally a rank ordered list of individuals. These 12,000 people are at the highest risk of becoming homeless among all of your clients. And let me just say now, lest anyone be confused, the research team never sees the identities of any of these people. We only work with completely de-identified data. So when I say a list, it's a list of anonymized IDs that someone who does work for the county within the healthcare agency can re-identify legally in terms of privacy laws. So I'm going to talk about this second experimental approach and what it looks like now at the county. So before I do that, though, I do want to make a point that these two approaches in LA, at least, where you have self-identification and being screened into prevention versus predictive analytics, are reaching two totally different groups of people, both of whom are at high risk of homelessness. And that's because predictive modeling is using service utilization data. It's going to find people who are high utilizers of these services that I mentioned, like emergency department visits, mental health care, crisis stabilization episodes, coming in and out of the county jail. The models are using that data, so they're selecting people who are at high risk of homelessness, likely because of the issues that they're experiencing that cause those frequent interactions. Whereas people who self-identify and have the capacity and functionality to navigate their way through the bureaucratic process to get enrolled into prevention typically don't have those kinds of service profiles, right? And our theory is that they have a rapidly developing financial crisis that they can't resolve. It's the last straw. They're about to become homeless, right? So both of these groups are really important. The message isn't that one strategy is better than the other, it's that they're reaching different people, and so you need both. And arguably resolving homelessness crisis for that rapid financial client might be easier than resolving homelessness risk for someone with a lot of complex needs. So when we started the predictive modeling, we started it just purely as a proof of concept. Could it be done with the data available to Los Angeles County? We produced a paper in 2019. The Board of Supervisors approved it as a good enough that we were able to predict homelessness with much more accuracy than random guessing or even through typical screening programs. So they approved a pilot, and that pilot is now operating, and it's called the Homelessness Prevention Unit. And the partners are DHS, the Department of Mental Health. This is actually a DHS program, so I'm speaking on their behalf. But it's intentionally partnered with DMH because these people tend to have a lot of service history in both departments. And then, of course, the CIO of the county is a hugely important partner because they're providing the data infrastructure to do the modeling that our group does. So one key thing to know about the HPU is, unlike really any other prevention program really in the country, we're not waiting for people to self-identify. HPU is proactively reaching out to people who are disconnected from services. And they're doing that because our models are saying this person is a really high risk at this moment in time. So I'll come back a little in a minute to the program design. These are just the partners again. I wanted to point out that we have a community advisory board for this project that we meet with on a quarterly basis. It's mostly people with lived experience of homelessness, but also some service providers, people who work at legal aid, people who work in the child welfare system, to help us design, help the county design the intervention and for us to vet research findings and data. We also have an independent technical advisory board looking at things like equity in the modeling and whether our evaluation of the unit is up to snuff. So we have some safeguards there and external opinions. So how does this work? The California Policy Lab uses many years of county data linked at the individual level. We run the predictions, and we're looking at a sample of about 80,000 people with a recent DHS or DMH contact. And the reason why we're conditioning it on that is that they need to be able to contact their own clients if they're doing outreach. So we start with recent clients of DHS and DMH, and then we generate the risk list, and it's about 12,000 people of the 80,000. And that 12,000 group on average is 34% likely to experience homelessness in a short period of time, whereas the rest of the sample, only 2% are likely to experience homelessness. So these people are at much higher risk of homelessness than your average recent DHS or DMH client. We send the risk list to the county. They re-identify them as the healthcare provider, and they literally call people and ask them, you know, I'm just checking in. This might be a challenging time. Do you want to share with me what's going on in your life? Can you share with me some details about your housing situation? And the pilot started about a year ago. I believe maybe a little bit longer, and it was really striking to the county. Like right away, they were talking to these people, and their housing situations were extremely precarious. Like many people were days away from losing their spot in a garage where they were doubled up with a cousin who was a leaseholder. You know, so I mean, like these very, very sort of attenuated housing situations. Most people have a recent mental health history and have complex health needs. Many have histories in the criminal justice system. So then if the person agrees to be part of the program, they implement the intervention. And one of the things that's unique about the intervention is that it's highly flexible. It's a flexible pool of funding that they can use immediately. Maybe they need the meal that day. Maybe they need emergency rental assistance. Maybe they need one of the clients featured in the LA Times needed a breathalyzer installed in his car so that he could go back to work. So they want to help people become more self-sufficient. So there isn't a standard set of resources. It's really customized to the person's needs. It's about 4 months, and the average amount of rental assistance is just over $4,000 per person. So that's interesting because if these people became homeless and needed to be rehoused through a PSH unit or a subsidy, obviously that would be a lot more expensive. So we've had about 92 people who we've either completed or are currently enrolled, and they have a 90% retention rate. We're doing a rigorous evaluation, so we don't know yet whether this is reducing homelessness compared to the control group. But this is a pretty promising finding, considering we would expect these people to have a 34% chance of becoming homeless in this time period. And now the pilot is expanding to families. So I'm just gonna briefly switch gears, Ronson, unless you want me to stop for lack of time.
Yeah, no, that was really interesting. Actually, if you can go back really quick, a slide. I had a quick question, like, so like in the LA Times article, the lady profiled in there actually had a Section 8 voucher. And so my immediate question was like, oh, you would think like someone with a Section 8 voucher would not pass the screen as someone that is on the verge of being homelessness. Can you talk a little bit about that? Like why there's like that disconnect in my head?
Yeah, no, that's such a great question. And I think that, you know, the county makes the decisions about ultimately once we send them a risk list, who is or is not eligible for the program. And I think the county has always been interested in prevention within the housed population, right? So there's also a form of prevention that's making sure people maintain their vouchers or their units, because if they don't, even though they're on a voucher, they're going to enter the shelter system or the street outreach system, right? So I think that that's how the county thinks about that. Most of the HPU clients are not on vouchers. And it was interesting that they happened to interview, you know, one of, I think, a small handful for the article.
Okay.
So let me just, more just for your visibility, I'm not going to talk in great detail about the second report I wanted to cover, but we did recently complete an analysis for the Department of Mental Health, looking at 1 full year of enrollments in street outreach across the entire county and how many of those people had a service history for serious mental illness. And then we looked specifically at how many of them had a service history for a psychotic spectrum disorder. And that's because there is, in terms of street outreach strategies, exits from homelessness, and other care and services, from DMH's perspective, there's a pretty big difference between someone with a psychotic spectrum disorder and someone with a mood disorder, for example, major depression. So if you talk about the broad category of serious mental illness, you're really mixing these two groups, and they wanted more visibility into how distinct they are and how many are in each of these categories. So this is just the main finding in the report, which is that 17% of the sample in 1 year had some service history for serious mental illness. And that data is pulling not only from DMH, but also from DHS. So if someone is taken to the emergency department and treated for a serious mental illness and they have no DMH care, they will still be in our data set. 10% of the group that had SMI specifically had a psychotic spectrum disorder. And we looked at 5 years of service history, but everyone in the sample was homeless and living on the street in a very recent year, fiscal year 1920. So depending on your orientation or what you think, this might look like a small number, or it's much smaller than you expected, or it might look similar to what you've seen before. I always like to caution that anytime you're looking at administrative data, this is going to be a minimum estimate. This is the minimum number of people who have this condition, because if someone is disconnected from care and services altogether, they're not going to be in the data set and you won't see them in here. I think the way to look at this is that the county knows there are at least 4,600 individuals on the street with psychotic spectrum disorder, and any system you build to end homelessness for that group could probably be scaled to reach a larger group if you end up needing to serve a larger group. It is interesting, Victor just presented their gaps analysis, and I tried to make a note, but the slide moved quickly. I think they said something like over 80% of people in encampments needed primary care, and about 18%, I think, needed psychiatric care specifically, apart from behavioral health. That's not totally inconsistent with the finding here as well. And this is about what DMH clinicians predicted this estimate would be, that even though these people are highly visible, they're very sick, you see them, I think, more when you're driving around LA than you might see someone with no SMI who is living on the street. They estimated in advance of the project that we would get somewhere between 8 and 12% of the sample with a psychotic spectrum disorder. So their predictions were pretty accurate.
Janie, if I can interject really quickly, the 4,584, that's a key stat. And the rule of thumb for people in SPA 8 is that we're roughly about 10% of the county. So in terms of homeless count numbers, We're at around 8%. So in my head, I always just round up to 10, just make the math a little easier. So that means there's about 458 people in SPA 8 with a psychotic spectrum disorder that's on our streets. So that's roughly how the data extrapolates to SPA 8.
Yeah, that's super helpful. I didn't know that, but that makes a lot of sense. And I shared this with Ronson in advance of the meeting, but one of the things that California Policy Lab does for the county and LAHSA is think about data infrastructure issues separate from our research projects. So for example, how can you accurately geocode all of this data to give, you know, groups like yours or individual cities more immediate access to trends? And there of course, there are some ways that you get that information already. I'm not suggesting you don't, but there's actually a lot of really interesting and important conceptual questions around how to do that with the data. So we're working on a memo or analysis plan in support of LAHSA and the county for thinking about how to answer that more rigorously, you know, with the data available to you. Like, can you actually see how many people are being treated by DMH in SPA 8? But 10% is good enough.
Yeah, no, that's what we're working with.
So this last slide is just showing you the rates at which these groups were accessing housing, and we gave them a full year, every person in the sample, which is 45,000 people who were in street outreach in that year. We gave them a full year to observe what happened to them. Specifically, did they access interim housing, rapid rehousing, or PSH? We're not able to see things like board and care or residential treatment, or conservatorship or institutional bed placement. So we're only looking at resources in the homeless services system for this slide. And the interesting finding here is that if you have a serious mental illness, you're more likely to access housing than if you don't. So 33% of people with psychotic spectrum disorder had some pathway to interim housing, whereas, you know, 84% of the group without SMI got nothing in that whole year, right? So this is a pretty striking number, this not placed number. These are the number of people in street outreach in these groups who got no housing pathway at all. But I think one way to think about this slide is that there are some resources, this is particularly true at PSH, that are funded for this population. So it might be that you're seeing a higher rate of placement into PSH because units are funded specifically for people with complex needs. It might also just be a reflection of prioritization, that when you are given the triage tools and you score higher, which this group is likely to do, that you're given priority for things like interim housing beds. I think one interesting thing here is that there can be a narrative that people who with psychotic spectrum disorder in particular, that you can't house them, that you can't convince them to go inside, you can't convince them to utilize the shelter system. And we really don't see that to be true at all. And in fact, 40% of people with psychotic spectrum disorder had some kind of housing placement, whether interim housing, rapid rehousing, or PSH. So there's a lot more detail to this. We do demographic breakdowns of this data. We do demographic breakdowns of access to housing. All of that's in the full report, but I'm not gonna go through all of that with you today, and I'm happy to answer any questions people have about this work.
Okay, thanks. Ronson, any questions? I think Bill has one. Bill, go ahead.
Yeah, I just had a quick question. You know, I've heard numbers about, you know, a fair amount of people in our homeless population coming from out of state. And I just wondered, is that reflected in the proactive area, the prevention area, or how does that get into the data? Or is that actually an accurate assessment to begin with?
Yeah, I don't, there are a couple of data sources on this question, and they typically support the idea that most people who are receiving homeless services are very local. One is just the demographic survey that's done every year with the PIT count that tends to find, you know, close to 80% of people reporting that they're homeless near where they lived. The study that we did actually took the entire history of HMIS services. So any individual who'd been served by LAHSA or DHS over, I think, a 10-year period. And we took all of that identified information and sent it to the state and linked it to state wage records. And over 80% of the people getting homeless services had a work history in California. So like not only were they living here, but they were earning wages covered by unemployment insurance. So it was sort of further confirmation that, you know, these are our people, and people tend to experience homelessness pretty close to where they were housed, mostly for resource issues. I have heard from some providers, and I've never looked at this myself, that there are pockets in LA where you have a higher percentage of people from out of state, particularly I think in like the Venice area, you know, that might attract more people from out of state. So I'm not suggesting that every encampment is the same. They're all very different. But our research would suggest that most people are pretty local.
Okay. Yeah, I appreciate that. That makes sense, right? I mean, I can't imagine, you know, flood of people. I can imagine floods of people coming to California, but not necessarily that degree of homeless population. I think 20% makes sense. Appreciate it. Thank you.
Yeah, sure.
And I always just tell people when I'm advocating is that, you know, hey, we lost the congressional seats. So if anything, people are leaving California and roads, and not the other way around.
Other questions, please.
While people are maybe thinking about some questions, Jane, I just want to say, you know, thank you so much for coming. When the LA Times article came out, both my executive director and Lori, my analyst, emailed me basically at the same time saying, we got to, you know, bring this up on our next task force meeting. So I'm really glad you can come. I think, like, for me, the biggest takeaway, especially on the mental health piece, is that, you know, remember going back to that 10% number, the 458, serious psychosis disorder that we're seeing on our streets. You know, I'm kind of going through the bed counts in my head of the crisis beds that we have in the South Bay. And I think we have at best like maybe 120 beds. So we're like a few hundred beds short. And talking to providers, you know, a provider just last week told me they thought the South Bay was a service desert and that we lack a lot of these mental health resources. And so that's something I'm definitely working on. So I'm really glad that your research is highlighting that there is a gap of mental health crisis beds that we need to get these people off the streets so that we can triage a mental health disorder in a facility. So that's the big takeaway. And so I think this task force, one of our to-dos is to find the other 200 beds that we need to fill that gap.
Yeah, I think that's so important. And there are a lot of really important resources, some of which are local, but some of which are funded at the state level. And I think paying attention to the board and care reimbursement rate, which is the state legislative agenda item, you know, is really important for this population. We're losing those beds because the facilities can't operate. And really connecting those kinds of policies to this population is I think, a really important set of projects to do for sure.
Right. And then on the predictive analytics side, you know, we'll be interested in following you as you continue on this pilot and look at the control numbers. We have a lot of data geeks in the SPY area, so you're welcome to anytime to come back and kind of update us on that research.
Yeah, absolutely. Thanks for your interest. And of course, they are serving clients countywide. So presumably some of your folks are in this very small pilot, and they're trying to expand to have at least 1,000 people per year in the program. And I think the other thing to pay attention to with the HPU is just the service model itself, because this idea of like a highly focused, very flexible, nimble group that can unlock all kinds of county resources, whether it's primary care or behavioral health or rental assistance, like that's a really different way of thinking about it, you know, that's more nimble than the big CES, like where am I in the queue, you know, among thousands. So it might be a model that could be taken out of the prevention context and applied to other populations as well.
That's a great point, because we actually do have a small version of that called client aid that we can immediately cut, like security deposit checks, for instance, for folks. And so I wonder at what point maybe the county would be ready to share that model with COGS, and so that we can maybe use Measure H money to kind of implement that locally.
Yeah.
Okay, I don't see any other questions, but Janie, we thank the Bruins for doing what you're doing. It's a pleasure to have you here, and I'm sure Ronson will have more stuff for you and more questions, as well as Lori. So thanks for coming on with us, and we just appreciate your presentation.
Thank you so much. Have a great rest of your day.
Okay. All right, so we're moving on. Task Force project updates. We'll go with Lori and Ronson.
All right, so good news on the client aid front. We got our debit cards, and so we'll be releasing those out to Harbor Interfaith is going to get one, PATH is going to get one, and St. Margaret Center is going to get one, and then we have 2 at the COG as well. So this is for any outreach worker in the South Bay. Lori is going to share kind of a form that she did, just some quick instructions on how to access that money. We want to be the provider of last resort. So we want to make sure that you extend all the other county services, lots of services that are available before you come to us. And so Lori, do you want to kind of share what you put together and walk people through that?
Sure. Are you able to share the screen with the form?
I have to pull it up.
Maybe I can find it sooner. Let me see. You got it? Or
Not yet.
I got it.
Okay, cool.
Did that work? You can see that?
Yep.
Okay, great. Let me see if I can reduce the size of that a little bit. Okay, so the goal here is we want to make the client aid available to everybody as the last resort, and we want to keep it as simple and as quick as have access to the funds quickly and not make it difficult. So starting with step 1 on the process. So first thing you do is email Ronson and I both, because we want to always be able to answer you with a request within about 24 to 48 hours, because this is usually has an immediate need. So basically, if you have a need for client aid funds, you're going to give us in the subject line, put the first person's first name and say it's a client aid request. That triggers us knowing this is urgent, how much you're asking for, and give us a pretty detailed explanation as to why you need the funds and how this is a last resort. Problem solving didn't work, etc. We'll answer you right away, either saying, yep, approve, move forward, or ask you for a little more information, or possibly, not very often, reject the claim with an explanation. Usually they're going to get approved. And then as soon as you get that green light, you're going to click on our form and just enter the information, okay? And go through all the fields, and then you're going to hit submit. And it comes right through to us. Our accounting department has access to this too. You'll also need to send us receipts. So if it's a motel stay, be sure and send us the receipts. If it's for documentation, whatever it is, copy of an invoice. Soon as we have all the documentation, we can go ahead and reimburse. Now, if we're reimbursing you directly, we just need to have a W-9 on file so we can set you up as a vendor. We can set up, if you're working with a particular hotel all the time, get us their W-9 and we can pay the hotel directly, save that step of you having to lay out the money. And then there's a picture of a debit card, sign in and sign out for the organizations using a debit card. It's really that simple. Just make sure before you enter it in the Google form that you've gotten our approval. And like I said, it's last resort, but security deposits, if you've got a landlord who said, yeah, sorry, we're not going to let you have this unit because somebody else can pay the security deposit sooner, send that to us. Ronson, am I missing anything?
Yeah, no, I just want to add, one thing we don't necessarily do is meals, because, there's food pantries and things of that that we like for you to kind of maybe try first, churches and things like that, giving out food. The other thing is that we'd like for the client to kind of have a plan in place, like a near-term plan, either to get shelter or housing, because, we just don't like indefinite, kind of motel stays and things like that. So we just ask that a good candidate for this would be someone with like an immediate housing need, within a couple of days. They just need maybe a respite because they have health issues or something like that.
Right,
So,
exactly. So as I mentioned last month, no open-ended requests. But just to let you know, the client that Sherry Weaver was talking about early, the 88-year-old woman, we were able to put her up in a motel until the Torrance Village opened. So there's an example of, we got her off the street. I couldn't, we couldn't stand the idea of an 88-year-old woman sleeping on a park bench. So I'm keeping it simple. Does anybody have any questions? Okay, we must have covered it all, Ronson.
yeah. Okay, so the next thing I wanted to talk about, so we covered the Torrance shelter. I want to go back to the rent relief stats. Hold on, let me pull it up. I just had it up. Oh, here it is. Okay, so let me share this. So this is for cities. So what this data is telling us, and thank you, Lori, again for finding this data. But so California had the man, what was it called? It was a rent relief program. Housing is Key. Yeah, that's what it was called. And it paid, background going back to the beginning of the pandemic, which was super generous. And so for LA County, there are 242,000 total applications. South Bay had 16,644. Interestingly, like I was telling you earlier, that's about 7% of 241. So I always just round up to 10%. We're about 10% of the county on a lot of metrics. And so 16,644 people applied for this. So that means that them and the landlord were both in cahoots saying, okay, we got a problem. You're not paying your rent. Let's seek help from the state and let's apply for this rent relief program. And then the county, I guess, did know that 67,000 of the folks were actually facing a immediate eviction problem when they applied. And you can see that all cities had this, and even our more well-to-do cities like Manhattan Beach also had these problems. They had 46 people that were at risk of an eviction. We know that 60% of all homelessness is starts with an eviction. So this is something that, again, I think is very important for us to keep track of. So you can see these numbers are pretty large. A large number of our neighbors were in deep trouble. The state did pay out 8,000, so a little bit. It was close to 9,000, so a little bit more than half of the applications. They did deny 4,000. I don't really have much color on why people were denied. Maybe they just didn't meet the qualifications, or there was some other issue. Maybe the landlord didn't back them up. I don't know. And then there's still about 1,200, roughly 1,300 that are still pending review. I think there's still a lot of consternation that this process is kind of too slow. I think the state were overwhelmed by the number of requests. But I wanted to share this so that you guys can see the data. We'd love to also maybe share this with the cities as well, and we'll be posting this as well so that you guys can see kind of the underlying eviction issues that tend to go unnoticed, in our day-to-day. And on that note, I also wanted to share. There's actually good news on the mortgage front. So this is rent relief, but there's also mortgage relief now. So, and this is going to be something that might be important for seniors or people that are really affected by the pandemic. But if you have a pandemic related hardship, there is mortgage relief. They will pay, if you're behind 2+ payments on your mortgage, they will pay for that. They also can provide property tax relief. So this is a new program that's out, and wanted to spread the word on it. So that's a link, and we can all send this out as well. I think that's pretty much it for the COG updates. The last thing I just want to note is that there's been some community meetings going on in Redondo Beach. They are putting up a home key site. There is some opposition Locally, they're a little bit upset that I guess the site's on PCH is as commercial as you can get, but it does back up into some residential neighborhoods. So we're trying to go out to the neighborhood and to the community meetings and provide information on why this is much needed, how it's an extension of the Redondo Beach Pellet Shelter. And so we are going forth with that. Harbor Interface is going to help us with this kind of community social engagement. They're going to provide blurbs of people that are currently in the pellet shelter so that people can see who they are and know who those are, the folks that are kind of moving into their neighborhoods. Because what's happening in these community meetings is that people come into these meetings with the notion that it's that crazy violent guy that they might have encountered in the past, who's homeless, who's a drug user, and that's the people that they're moving into their neighborhoods. And so we're saying, no, that's a wrong stereotype. We want to put a different image of the person in your head, the 88-year-old lady that's going to the Torrance Pellet Shelter, all these other folks that we're helping that don't fall under that stereotype. So we're gonna go forward with that. We'll probably put together some sort of campaign on that, and it's not just gonna be Redondo Beach. We'll hopefully go out to all the cities with that as well, so that we can share success stories in every city. So that's all the updates I have.
Thanks for the updates. Is there any legislative updates that you know of, or is Jackie going to bring those up?
Janet Turner's here. I don't know
Oh,
if she.
I'm sorry. I apologize. Janet Turner.
Hello. I was hoping that we were going to be releasing what has gone through the House with regard to community project funding, but we are not quite ready to release that information. So next month, or of course, I'll be emailing you as soon as that information is released. But that's the next big step. And we were very happy. The Congressman was very happy to be able to get $1 million for the city of Torrance to help with outreach workers and infrastructure needed so that they could help people in encampments and of course create the tiny villages. It's my pleasure to be at the ribbon cutting for the tiny houses. And so again, fingers crossed, we'll see what gets accepted. And hopefully maybe we'll have some more community project funding for you guys. Thanks so much.
Oh, thank you. Appreciate it. Is that the only thing we have, Jackie, for updates?
Well, we have many. I was just looking at our matrix, and there are bills in the legislature, but they're in recess right now in the summer recess. So we're monitoring several bills, and we're supporting other bills. The one thing that I wanted to mention is that we are our legislation to form a housing trust fund looks like it's passed committee in the Senate. It came from the Assembly as a different bill, so it has to go back to the Assembly, I think. But it looks like it's going to get through. The problem is now that we have no money. And so we've asked our state legislators to help us with an earmark for the housing trust, and also for an earmark for other things that the COG does that are not funded, like promoting climate change and reducing greenhouse gas emissions and electric vehicles, and a lot of things that we could do right now, which would advance state goals, but we can't. The budget has passed, as you probably have read in the paper, but we understand there will be trailer bills that will go through, which is just sort of playing on the fringes with the budget. And so we're trying to figure out how we can interest people to get involved in, our legislators to get involved in helping us with some funding in the trailer bill.
Okay.
So that's where we are with those things. And we had election of officers, and I'm pleased to announce that Rodney spent June in 2 elections. Not only did he win re-election to the city council, but also is the second vice chair of the COG, and we're delighted about that.
Thanks, Jackie. I appreciate that. I appreciate the confidence. Thank you. Okay, with no further legislative stuff, Jackie, the COG is all yours. Updates on the COG.
Those are pretty much my updates.
Is that it? Okay.
Yeah, I don't know if, Ronson, I don't know if you usually talk about it, but you might want to talk about the next, if people don't know that we have a senior services committee, which does address a lot of the issues that of people concerned about homeless, you might want to tell them about what's going on at that committee.
Yeah, we have actually we have a new provider coming into our area, and this is really important for seniors because you know, one of our fastest growing populations in homelessness is seniors. We're getting like it feels like a call a week, right, Lori, about like some senior being evicted or needs help, and it's just horrible. And so this group is actually providing shared housing for seniors, which is great if you're on fixed income like Social Security. They are only charging $700, $800 a month for rent, which is perfect for someone on fixed income. And you know, it's a shared housing model, and they also provide, you know, pair you up with IHSS services. So like if you need in-home care, they can provide that too. So that the person I met with them, they're based out of Orange County, and they're moving up here. They actually have houses already in Hawthorne and Inglewood. And so they're just looking to fill some vacancies. And they also want to meet with cities. I still need that to add my to-do list to kind of talk about you know, opening up more houses and just making sure they're on the right side of the planning folks on that. So that's going to be at our next senior services meeting, as well as Scan Health is also going to be presenting their model to provide seniors with care. And yeah, this should be a good meeting.
That meeting is July 26th at 9:30 in the morning. And I did forget that I did want to make two more announcements.
No, go ahead.
One has to do with our SCAG money. We get money from the Southern California Association of Governments to look at promoting housing. And we're looking at the money to use in a way of understanding what the housing situation is. So we have money for what we're calling the Housing Education Forum. And we would have 10 sessions that will be that we will Zoom. People, what we're asking is for people who are interested in this subject, not city family first, but then others that are truly part of what we do, to come to these forums and help us really get the word out on what some of the constraints are in the South Bay, what it costs to build a house, why it costs that. We want to have developers come. We have money to pay expert speakers. What we don't have, and what we desperately need, is an advisory committee, because we have the names of the sessions that we want to promote, but we want to have a committee of stakeholders, planning commissioners, city council members, community development directors, and anyone interested who's had an interest in housing, saying, well, could you discuss this? Could you discuss that? So we're trying to fine tune the scope of work. And if you are interested or know of someone that might be interested in serving on our housing advisory committee, we are looking for people between now and August 1st. It's not that big a commitment, but we really do need that advice. The second thing I wanted to mention is we've brought several times, I think, the issue of the local travel network here. And it's really, I think there's an article today in the Daily Breeze about it. We just let a contract to Fair and Piers for signage. And last night I was at the Lomita City Council, and we're getting nothing but favorable responses. And today I've got an email from somebody who lives in Torrance that says, how can he help? So we're especially excited about this, because I think I told you, but if I didn't, when we started looking into these the vehicles, low speed vehicles, we found out that there are some vehicles that are specifically for disabled people that have trouble getting around. They're very, very low cost, and yet they're going to provide independence for people that currently don't have it today, and would help somebody get to a job, for example, without having to buy a car. So we really want to promote the local travel network. And if you have any questions, please feel free to contact us or tell your city council that you'd like it in your city. Thanks.
Thanks, Jackie.
Oh, hey, Ronnie, I do have some more updates. Jackie, by the way, I just joined the e-bike gang, so you'll see me right around the South Bay in my leather jacket and spike helmet. So I'm so excited about that. I shared that with my wife, the article that came out. Torrance is opening up Section 8 vouchers. So for those that missed out on EHVs, we have information on that. They're prioritizing certain demographics like families, for example. So I'll have Lori send that out to you with the meeting notes. And almost forgot about that. And then what? There was one more. Lori, I feel like we're forgetting something. Let's see.
I think you got everything. I'll resend, we're working on getting that eviction and tenant rights flyer also created in Spanish for some of our areas. So I'll include that in the updates too.
Yeah. The other thing is, Lori, you're working on an educational thing. So we, with Courtney and Lori are going to be, are working on this educational presentation. We, with the recent elections, we're gonna have some new leaders and we want to re-engage cities on kind of like, again, homelessness 101, myths and facts. So that is something else we're working on as well.
Okay, that's good. Is that it? Okay, Jackie, under announcements, I have a quick one. The next homeless task force is 7 September. That's the same time as the California Cities convention
Right.
in
right.
Long Beach, and that's where I'm going to be.
Well, we might not want to have it at the same meeting as I guess most of these people don't go to the League of California Cities.
If I could have you or maybe Ronson run that meeting for September,
Okay.
would that be
That's
okay?
right. I think so, unless other people are conflicted by it. If so,
Anybody
please.
else having a confliction with the 7 September meeting? I'm a part of the California City, so I'm the city's
Right.
representative, so.
Thank you for bringing that to our attention.
Okay,
We'll
so
keep
yeah,
that.
so I'll let you guys decide on who takes charge that day. That would be good.
Okay, sure.
Okay. All right, any other announcements? Wow, hearing none, I think we got done a little early again today, huh?
Yeah.
Okay, well, I appreciate everybody coming on. We had great attendance today. We started out with a little over 40 people. That was great. Thanks for the two presenters. The information that was given out today was excellent. So we appreciate that Lori and Ronson got them for us so that we could hear more updates on things that are happening. So with that, I'm going to adjourn this meeting and send everybody on their way. Have a great Thursday. Bye, everybody.
Thanks, Councilmember.
See you. Nice to see you, Jackie.
You want to stop the recording, Ronson?
Oh yeah. Oh, Wayne was here. Redondo Beach PD.
He still is here.
Yeah.